Bonjour, bonjour. It is delightful to have you all here for the continuation of a series where we are saying no to Meno, at least no to the myths and no to the way that it's been presented to us as women, where we are trying to reclaim all of that, as well as a cat. This evening, I have with me two wonderful doctors to start exploring this topic with us. I have Dr. Tracy Steady Hardcastle and I have Dr. Betty Murray. Ladies, welcome. How are you today? Both in green. I love it.
Wonderful.
Yeah.
Likewise.
Yeah. So, audience, for your awareness, this is the third installment. And in the prior two installments, and Katie or Vanny are going to toss webinar links into the chat so that you can have access to those. We did really extensive conversations around bioidentical hormone replacement therapy. We demystified it. We discussed how it can be helpful, in particular in terms of longevity. And this evening, part of our goal is going to be balancing out that conversation a little bit insofar as speaking to other options you are empowered and enabled to explore with your care providers so that you can find what fits best to us or best to you. So, why don't we start into that conversation? So, if a woman is approaching their provider, and they're like, hey, I think my body's going into perimenopause, or hey, I think my body's in menopause, and I'm looking for some support there. What are some options that either their medical doctor might be offering or other care providers within the space might be offering up to them?
So would you like us to cover the things that are often used in adjunctive therapy? Are we going to start with conventional medicine first?
Let's briefly start with conventional, and then we're going to dive more into the
Okay.
adjunctive supportives. Yeah, yeah.
What's interesting is often when you start talking about hormones, it's more so around symptom control.
Mm-hmm.
So I think a lot of what people hear when they talk to physicians is they look at it as a cluster of symptoms to control. So it might be, okay, you're not sleeping, so I'm going to give you
Mm-hmm.
a sleeping medication, from Ambien to whatever. And then it's okay, you're anxious or you're depressed, so therefore I'm going to give you an SSRI. Or
Mm-hmm.
or your libido is tanking, so I'm going to give you there's a couple drugs that are in that kind of pathway. I'm having a menopausal moment, I can't remember, Vioza, I think it's Vioza, I think is right, that helps with libido. So often it's a
Mm-hmm.
clustering of medications. If we take sort of HRT off the table, it's often, I would say how we look at medicine conventionally in the United States and in the Western world is there's a symptom, we need to suppress the symptom. So often it's a clustering of different combinations to sort of suppress that experience. For birth control, a lot of times if you're symptomatic pre-menopause, the year after
Yeah.
having a cycle, a lot of times the answer is conventional birth control to sort of just suppress, any leftover variation.
Mm-hmm. Mm-hmm. So if I'm hearing you, woman, oh, please, Dr. Study. Yeah.
I was just going to say, or things for mood, or things for pain. Those are the other two
Mm,
places where I think it can show up and and the hormonal impact not be recognized immediately.
Right.
yeah. Yeah.
Exactly.
Yeah. Okay. So purely if we're purely looking from this from a conventional, you're showing up to your GP lens, once HRT, BHRT is off the table, it's a lot of symptom management. And so there's an element of woman must say, this is what I'm experiencing, and doctor will address it simply based on that, not really a whole picture.
Yes. Yes.
Okay. Okay. And so, what if we were to go to an alternative care provider? So, someone that's, and this can include MDs, I want to acknowledge that, but someone who's really done additional training in this space to understand there's the medication route, there's the hormonal replacement route, as well as there's this other complement of interventions. What comes onto the table, or how would you start that conversation? Is it purely an intaking of symptoms again, or are we considering genes, or how does that conversation start as to, the multitude of options that are out there, whittling it down to what's appropriate to the person before you?
So I think Dr. Steady Hardcastle probably can talk a lot about, non-pharmacological interventions, right?
Yeah.
would say if there's one area, Chinese medicine just excels at treatment
Hmm.
across the board with non-pharmaceutical, interventions.
I agree.
Yes, I did a lot of that in my practice. And, now I, of course, have the genes layer. So that would be something that I would take into consideration, certainly. But it was not for, 18 years. So that intake is a lot about what are the symptoms, because perimenopause and menopause can look very different for different women. And of course, some of that is
Yeah.
genetic, some of it is lifestyle, some of it is, there are a lot of different reasons for that. And so we would address it by pattern and then typically use acupuncture and herbs or one or the other to work on that.
Yeah. And are the herbs, and I appreciate different herbs are going to kind of target different things, but those herbs will target largely hormones, but there's also an element of those herbs also support some symptomatic relief.
That's right. So if it's hot flashes, for instance, that's, one of the classic
Yeah.
symptoms that always seem to be talked about, then there would be herbs that might work specifically on that symptom. And I would also, talk to people about lifestyle. When we were meeting briefly
Hmm.
before, we were talking about things like alcohol, and then there are things like even um, fiber, which is really great. We need to keep our bowels moving and we need to help that to clear out estrogen once it's been metabolized to a certain point. But if people are consuming a ton of fiber at the same time that their estrogen is dropping really quickly, then they can actually feel
Hmm.
worse. And so then it's about finding that sweet spot. So even things that are good can kind of be done to excess at various points in time. So it's really about looking at the whole person and how they're living and figuring out what's best for them and things. And when it comes to mood, then yes, there are herbs for mood and for sleep and things like that, but also sleep hygiene and meditation and all of these, talking about it with your friends. I think that generations before didn't really talk about it. I mean, my grandmother did, if
Mhm.
I'm honest. She talked about her hot flashes and having to keep the window
Yeah.
open. And she was like, and I smell different than I used to. Like these are things that like I got to hear as
Yeah.
her granddaughter, but that I think are largely not really talked about. And so, being able to have this experience, fortunately now we're living in a time where it is talked about quite a bit, but just
Yeah.
finding, expressing it, I think is also a really important thing.
Yeah.
Yeah. Yeah, I would agree. And I think what even gets missed for a lot of people that might even be treating with bioidentical hormones is, like Dr. Steady Hardcastle said, every woman's experience of menopause can be slightly different. It's not just hot flashes and night sweats. Like those are just two of
Yeah.
a cascade of things. And we have to remember that the body's endocrine system, so the parts of your body that make hormones, are a symphony. And so essentially you have your sex hormones, we're going to call them the brass section, and they are playing scat jazz after smoking some meth, right? And then other ones are like all of a sudden playing the blues. This is what they're doing every day. So I have, if you haven't heard me before, I have kind of a crass sense of humor, but I think you get my point. One day they're all over the place and it's really, really hyper. The next day they're in the
Yeah.
blues. And then all the rest of the symphony is trying to match. So you've got your thyroid's trying to match it, your adrenals are trying to pick up the pace. And so often you also get a cascade of changes there, that if you're stressed and you aren't doing the lifestyle, like you're not, sleep is a whole big picture, right? But if your
Mhm.
lifestyle isn't supporting those important things, like getting good exercise, not too much, not too little, eating appropriately, keeping the blood sugar balanced, and then you don't have good sleep hygiene, it's like you used to be able to get away with it, and now you can't get away
Mm.
with any of it. You have a
Yeah.
glass of wine, you're like, okay, I need 4 days to recover, and I also didn't sleep 2 of those, right? It's so
Yeah.
so I think the other part is recognizing, as you put these things together, and whether you're using herbals, which I know we're going to talk about in kind of the broad swath of those things, is the underpinning is you have to like work at it now. We have to put some effort into taking care of ourselves, and it's not just your sex hormones that are affected. Menopause is a full body effect, and you have an
Mhm.
entire endocrine system that is also trying to adjust to that change. And so
Yeah.
you have things show up that weren't there before.
Yeah. So if I'm hearing you ladies correctly. There's definitely an element of going to doctor and presenting with this is what I'm feeling and getting purposeful support there. But there's also a consideration of almost, and I want to differentiate, diet and lifestyle from a treatment perspective to diet and lifestyle. This is a transition, and because it's a transition, some things have to change. So, is it fair to say that as women are in this perimenopause, menopause state, there needs to be a sincere questioning of how they're living and the fact that even though it may have been perfect and healthy for them in their menstruating years, they may need to reimagine that. And what does that look like now that I'm in a new period of my life?
Yeah, I'd say it's very much the latter. A lot of what often may have worked for you before, and let's qualify worked for you. What does work
Yeah.
for you mean for most women? Worked for me meant I could get away with the food that I ate, but I could burn off what I did, right? So exercise was my greatest form. Let's face it, exercise is your greatest form of
Yeah.
punishment. And I could punish myself in a certain way and be able to make my body look a certain way, because that's what most women think about, right? We think about what's the physical appearance, right? But yes, that I think it's the important part to understand that that the things that often got us here are not the
Mhm.
things that are going to support us in this next phase.
Yeah. 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 So a pausing and appreciating that it's a change
Mhm.
and there needs to be a reconsideration. Maybe there doesn't have to be change, but a reconsideration and openness to change.
Yeah, or just looking at it and going, really evaluating and say, okay, I was doing that before and I'm not getting the same effects in this particular area. You might have two areas that are great, but
Mhm.
let's say your exercise is no longer restorative. You feel, like hammered crap when you get done and you need to lay down. And you know what I mean? Like that is a sign that you need to reassess that what you were doing is no longer right for you in this moment. And I think it's a lot of times we're scared of that because it's like, but wait, this is what I've always known, and it's just like your kids having to learn how to go and live on their own, go off to college. They have to go through that transitional painful
Yeah.
period, and they usually make some pretty big mistakes in the first year while they're figuring it out. And we have to give ourselves the same grace that we're going to have kind of that college going off to college experience.
Yeah, I think maybe we're going to talk about this a little bit later, but since we're here, I think there can be some resistance and even some grief about
Mhm.
having to do things differently, what that means about us.
Yeah.
If you think about like the archetypes of maiden, mother, crone, like nobody wants to be like the witch in a Disney movie. We want to be the princess or the mother, something like that, right? It's there's can be resistance to
Mhm.
moving into that next phase, which you can reframe it and think of it like wise woman or
Mhm.
um I get to do things for myself now. But I think that still that
Mhm.
change can feel so big. And if you're also having like sexual side effects
Mhm.
and your body doesn't look the way that it used to, and all of those things, that then feeling like you have to give up your wine and you have to really pay attention to certain things that you didn't have to before, there can be really this feeling of loss. And so just acknowledging that, um,
Yeah.
and thinking about the things that are good about it, the
Mm.
things that we can let go of,
Mm.
perhaps the over caretaking of others, the whole setting ourselves on fire to keep other people warm thing not happening as much
Yeah.
anymore. That can be a really positive side effect. So if we're able to talk about it, then we can reframe some of the things that seem scary or negative into more positive aspects.
Yeah. Yeah. I think I'm glad you said that because I think a lot of times I know from, my, multi-decade time in clinic, a lot of times I would say early, like if you look at the kind of stages of menopause, kind of early perimenopause, you get the kind of, what is this? you know, and then you get the, no, not really. And then you get the, now this is something new. Right. And I think
Yeah.
when you get, I'm on way on the other side of now this is something new at 55. I like I have such a different and better outlook. Like,
Mm.
you know what I mean? Like all the cares of what other people think and oh, how do I need to worry about, what I say in front of so and so? What are they going to think about me? I don't care. Because I'm like, either they're going to like me or they're not. But the reality is, if
Yeah.
I pretend to be something, you know what I mean? Like all the stuff that I think we spend a lot of mental and emotional baggage time on, it
Mm.
really, I don't know, for me, all of that went away. Like it is, my filter is broken, and I'm actually quite appreciative of it. But lots of women will say that. But what comes along
Yeah.
with that, even if you keep your filter, what comes along with that is this looking forward. My experience has been
Mm.
working with both men and women. We see a lot more women than we do men, but the reality is women often start to change their perspective at like, oh, what do I get to do now? Because I am not setting
Mm.
myself on fire for everybody else to keep them warm. I can think about me. And so
Mm.
there's this very forward looking, great outlook, that almost all the people you think about in history that were women that left their mark did it after 50, not before. They weren't doing that crap at 25. They were 45, 55 after that. Right now, I find often men feel differently, right? They have a different perspective. I would say it's a more negative perspective, and it's probably because we have a little more conversation around it than men. But I think if we can kind of make it through and kind of go, oh, I'm in that phase, and oh, okay, what is that? And then the next one is like, this is going to be better. That we can really look at it that way.
Yeah. Yeah. So again, openness. Oh, please. Yeah, Dr. Study.
I'm just going to say that I think for me that some of the shifting started way before it was on my radar. And
Mm.
so I really didn't understand. I just thought that there was like something, I don't want to say something wrong with me, but I was like, what's going on? What vitamin do I need to take? What am I not exercising enough? Like what, or too much? Or because at the time I was training for a triathlon and my periods were just like crazy town. Like I didn't know what was happening. Sometimes they were short, sometimes they were long. And so I was looking for a different answer. And I was a practitioner.
Mhm.
So it might have been on my radar for someone else, but it was not
Yeah.
on my radar for myself, because I was clearly too young for that. Right.
Oh, me
So
too. Yeah, my perimenopause journey
Yeah.
started in my late 30s. I was,
yeah,
and everybody was like, "No, Betty, this is just your adrenals. It's because you just don't stop." I'm like, "That was perimenopause." Yeah, but the hindsight's always 2020, right? Yeah,
Yeah.
yeah. So you have to
Yeah.
understand, people like us who do this all day, every day, miss it too. So don't feel bad that you're like, "How did I not know?"
Yeah. And it will be, I think it will be for another stage, but I think the conversation of the age of perimenopause creeping down lower and lower, such that I know many doctors within the space of hormonal care are now starting to screen for it actively in early to mid 30s, because it's something, I think, to both of your points, it creeps up and it's not on people's radar because that shouldn't be me at this juncture in time.
Yeah, I think Flow, and I want to say it was Flow with John Hopkins. I may have the university wrong, the medical center. But they did a study looking at women tracking their periods on Flow, and they found that age group, of basically like 30 to 40, almost 30% of their users were experiencing what we would consider perimenopausal symptoms: hot flashes, night sweats, insomnia, abnormal periods, missing periods. So we do see a shift, and
Yeah.
that was subjective symptoms, and we don't know because they don't capture anything else other than symptoms. But I think it's meaningful to know each woman's individual, and there's never a time that it couldn't be on the table,
Yeah.
especially if you're knocking on those doors.
Yeah. 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 Okay, so audience, we do ask poll questions coming into this. So I'm going to ask Fanny or Katie to pop those up. Audience, we show up to support you. We show up to further what you're liking to know. So the poll questions help guide that conversation. So we'll dive into that. And then we're going to jump back into this conversation of herbs and transitions and all the things in between. We first asked you what describes your current stage of menopause, and a majority of our audience, 70% of our audience is postmenopausal, um, with about 20% being perimenopause, and then an 8% where some of these conversations are going to be very applicable, premenopause. Um, those that are postmenopausal, please do toss into the chat what motivated you and drew you in today, because I would speculate, even though you are postmenopausal, it doesn't feel like that in a consistent, happy way. And so we'd love to make sure we're supporting some of the things that motivated you to come here. From a symptom question, so we asked, what are you still experiencing? Mon Dieu, 70% of the audience ticked weight gain, metabolism changes, as well as fatigue. Those tended to be the bigger two. When we talk in the area of mood and cognition, about 40% of our audience is saying their mood shifts. There's anxiety and depression. Another 45% is again saying cognitive brain memory issues, very common things. And interestingly, 37% kind of that hallmark symptom that everyone talks about was only 40% of the audience, really speaking to that while it's important and kind of fancy and sexy in the way that it's discussed, it's not everything. It's not what most people care about. We then asked, have you tried any of the following to manage your symptoms? HRT, about 45% of the audience has tried that. 70% of our audience has tried herbal or other natural supplementations and supports. It'd be interesting, audience, if you want to toss into the chat what herbal supports, what natural supplements you explored. 76% changed their diet. And then there's a few other people that said they just did nothing. When asked the question of how confident are you in your current approach, and most of the audience, unfortunately, 45, almost 45% was saying not very confident, and a 38% kind of sitting in between. So hopefully, audience, as we continue through, you're going to feel a little bit more grounded, or at least know where to go with next steps. We asked if you've explored your genetic profile as a tool to helping with health decisions. 70% had said yes. So I know we'll definitely speak to how, in particular, different hormone profiles can shift that experience of peri and then menopause. The last question that we asked here was, are you looking for support, potentially from a practitioner to help with this? There was a fair portion of the audience that said yes. And so to that portion of the audience, just make sure you let us know in the chat. The chat is confidential insofar as we see it, but no one else does. So you're able to put emails or other contact information in there, and then we can reach out to you to support with that conversation and seeing how we can be of service. So please do toss that into the chat. If you prefer not to, don't hesitate to email us. You can email us at ceo@thednacompany.com. We'd love to be of support. This area is definitely a space of passion for us that we really try to engage. So in terms of when we ask the audience kind of what do you like, 70% of our audience here is leveraging supplements, herbs, etc., to support their care. And in the chat right now, I'm seeing teas and essential oils, wild yam creams, and an herb. I can't pronounce this herb. Dr. Seti, are you able to pronounce the herb that Diane offered?
Was it Chatavari?
Yes, ma'am. Thank you. Too
Yeah.
many syllables for me.
Yeah, that's an Ayurvedic herb.
Yeah, it's
Yeah,
great.
yeah.
It's a fabulous
Yeah.
herb.
Yeah,
It's
totally.
wonderful. I can't say it. I type it out whenever I suggest it.
Yeah.
Yeah.
But
Yeah.
cohosh, dong quai, red clover, kind of usual
Yeah.
suspects.
Yeah, the usual suspects. And so I wonder if like oftentimes what I'll see, or at least see on a lot of clinical intakes, is a woman will come to me and say, going through menopause, I heard that red clover, or I heard that wild yam, or I heard that insert this herb would be helpful. And I started it. And my next question is like, well, did it help? And they'll be like, I don't know, but everyone said it would, so I kept taking it. What are, what are your advice when people are approaching herbs? Because there's incredible fascination. There's awareness. It can be a very supportive element. What's the advice when approaching herbs and you're in that perimenopausal state, that postmenopausal state, but you're still experiencing some symptoms?
Well, I think I'm waiting for Dr. Steady Hardcastle to go here because there's nobody that's going to know better. But I think, we have research on some of these herbs, right? We do have research showing things like black cohosh, red clover have these modulating effects on these, these hormone pathways. Maca, some more so than others, ashwagandha, Russian rhubarb plant, which goes by the trade name Estravera. So there are, what I worry about a lot is, belladonna is natural and also right. And the reality is, a lot of the supplement companies are unregulated. So you roll into your herb market and buy something, you have no idea what's actually in that bottle, right? Over the counter products. Like most of us, if we're using something that's made by medical brands that, actually lot test and do everything. But the other thing is you can get herb interaction, you can get herb drug interaction. And I think people don't think about that because they're like, oh, they're natural. So they're like fruits and vegetables. No, they're not, right? And they're highly concentrated in a way that you wouldn't normally get them when you're buying them in a capsule. So I also sometimes worry that people are like, doing polypharmacy with herbals and,
Mhm.
taking things that may not be helpful and then could be in some cases harmful. So I think it's important you really should be working with somebody that knows herbs, that knows your body chemistry. We've had people come in whose liver enzymes were off the chart, and it was because they're herbal
Mhm.
combinations,
Yeah.
and that's showing damage to the liver. And it's not going to happen to everybody or a lot of people, but I think
Mhm.
you have to respect these herbs in a way and understand that you don't just take a bunch of them together, like, oh, I took this and that didn't work, so I'm gonna stack this one and this one and this one and this one and this one. Because I get the shopping bags,
Mhm.
they come in and they're like, I have the
Yeah.
shopping bag. This is all the stuff I take.
Yeah.
I'm like, all
Yeah.
together. Okay. Yeah. So Dr. Hardcastle, I'd love to hear because you custom blend things for people, it's a treatment.
Right. And 100% to the shopping bags too. And then I have to kind of unwind that for people.
Mhm.
And I think people are a lot more interested in adding sometimes than they are subtracting. They don't know when to stop. They don't know when to say, "Oh, has it been long enough? Maybe if I just add this other thing, then that's the missing piece," right? Instead of thinking, "Okay, well, I tried that and it didn't work." But different people will have different responses to things, and because your buddy down the street, it worked really great for them, you have completely different genetics from them,
Mhm.
and possibly different symptoms. So it's just not a good thing necessarily and Amazon is not the
So
place to
do
get your
not buy.
herbs. They can be contaminated with things, even if they say they're from a reputable brand, maybe it's not really, you're not really
Counterfeit.
getting right. So really going through someone who can get them um, from a trusted place is really,
Yeah.
really important. And then knowing what the combinations are. When we were studying herbs in school, there are some that are contraindicated together, either because they
Mhm.
cancel each other out or because they have harmful effects together, and you do not want to combine them. And if they're canceling each other out, then you're just spending your money on nothing. So even if it's not going to hurt you, it may not be helping you to do all of those things. And so
Yeah.
um, this is where also layering in the genetics piece,
Mhm.
why did aside from their Chinese medicine patterns, why do some patients do really well on this and some
Mhm.
patients don't?
Yeah.
And the genetics really do play a major role in why that is. And
Mhm.
having someone who can either do a pattern diagnosis or look at your symptoms
Yeah.
and have a sense of what that looks like. Do you have a more estrogen dominant picture? Okay, then maybe they don't want to put you on this herb that has estrogenic effects. So even though hot flashes can be from low estrogen or from low progesterone, right? So even if you and your friend down the street are both having hot flashes, it could be from completely different reasons. And you don't want to take the same thing as them if you have the opposite pattern going on. A pattern in this case, meaning you're low in progesterone and they're low in estrogen, right? So someone else will put together a clinical picture of what's going on for you and then be able to make recommendations accordingly.
Yeah.
Yeah.
And it's, I think and again, the dose, the helpfulness and the harmfulness is dose dependent. Water is dose dependent. You can kill yourself with water if you get too much, right? And so,
Mhm.
that's the other thing. Some of these herbs have an upper tolerable limit based on averages, not individuals. And, you just have to be careful of that. So, you know, I, I agree with everything. And I think there's definitely validity to using some of these things, but it's important if you're really kind of going down that rabbit hole to work with somebody, that really does it.
Yeah. Yeah. And I would also offer, I think in particular, as you work with more and more people through that period, there's an element of, at what point when something's kind of going off the rails and what to be expecting next. And someone that can offer the wisdom through that transitional period, I think is really important because we talked a little bit about the loss of this awareness within cultures. It's kind of mirrors the twilight birth, right? For a generation, we lost our awareness around what the birth process was because of twilighting. And there's an element of reclaiming a lot of that wisdom right now. And a lot of that can be done through a provider as well as through friend circles, but a provider, especially in that more medical side.
Yeah. Yeah. And that's not to
And I
say,
also,
oh, go ahead,
go
please.
ahead. No, go ahead.
Yeah.
I was
That's
just
not,
saying,
oh. It's a Canadian traffic jam. Please feel free.
I love that that's a phrase now. Dr. Steady. Let's hear it.
I was just going to say that also the tricky part about perimenopause is that you can have these surges of estrogen specifically, where like the body's trying so hard to get to that ovulation,
Mm,
and needing the estrogen to reach a certain point that it may have been low and then it may be then high. And so you're like, oh, I feel so much better. Wait, I feel terrible. And I don't know why I'm doing the same things. And so having somebody help guide you through that and what to do when is also really helpful
yeah.
because it's not consistent yet. Once you're totally through menopause, things are
Yeah.
much more consistent than they are during perimenopause. Perimenopause is like, hang on, you know, because your body has its own thing. And it once you if you can get it to
Mm,
kind of calm down and support it during it, it won't be quite as crazy. But at first it can be a little, I don't want to scare anyone,
mm,
but it can feel less rhythmic. You know, we kind of count on our
yeah.
cycle to be a rhythm that we can count on. Like this happens at this time, and then I bleed for this many days,
Hmm.
and then suddenly it's not like that anymore, and it can feel really um,
Yeah.
just off. Like when you travel to the West Coast from the East Coast or vice versa, and your time zone thing is a little bit off. That's kind of that was how it felt for me with perimenopause. Like something just felt a little funky, you know?
Hmm. Well, and I think we have a lot of members that are, in the camp like I am, that is post menopause, right? And so, a lot of times you'll see these herbs Don Quai, red clover, black cohosh, all kind of as sort of additives, like because your estrogen is low, right? Now, there's not a single herb on the planet that is going to replace ovarian function. Believe me,
Hmm.
as a formulator, if I could hook you up with something in a bottle, I could sell over the counter, I would. We can't replace what the ovaries are not making. But a lot of these herbs modulate stress response and other things, so they often can be beneficial, like your
Yeah.
ashwagandha rhodiolas, your macas, and even some of these other ingredients, but they aren't going to replace the hormone. I think, and there are people perpetuating that story online, particularly on social media, selling products. I'm going to rebalance your hormones and I'm going to restore your hormonal balance. You can't, right? The ovaries, so here's the ovaries. It is an egg carton. It is empty. There are no more eggs left, right?
Yeah.
We can't produce that estrogen anymore. But it doesn't necessarily mean that everybody has to do hormone replacement.
Hmm.
Those herbs are going to maybe take the edge off, but they are not going to replace what was missing.
Yeah. 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 And there's, I think, the crux of a very personal and important conversation with your clinician, which I would offer is all the more important why you understand kind of both sides of the proverbial aisle, what hormone replacement can offer, what medication can offer, and then what adjunctive can offer, because you want to know you're making the best decision for yourself as opposed to necessarily what the provider that you're engaging with is best trained in, right? Because what they're best trained in is what they're going to be offering. And that doesn't necessarily make it best for you. So you knowing all the options means you can explore with a provider that can support that journey as you choose. Because no doctor should be telling you how to do this menopausal journey.
Right, right.
Yeah.
Yeah, it's an important part of informed consent that you get all the choices laid out. And if you have
Yeah.
somebody that's only laying out one, just recognize that's because that's the only tool they have. And you can go and find, it takes a village, right? It takes a village to
Yeah.
kind of navigate aging. The way to think
Yeah.
about it. It's good to have a couple
Yeah.
people in your back pocket that can really help you navigate.
Yeah. And I
And
think
I
that's
think
also, no,
go ahead.
please, please,
I was gonna say,
please.
I think encouraging practitioners to talk to one another so
Yes.
that you
Yeah.
don't necessarily feel like you're in the middle having to say, my acupuncturist said this, my functional medicine doctor said this, my GP's, just,
Yeah.
encouraging them because they can speak to one another and perhaps come up with something comprehensive. I know that everyone's busy and some people have a lot of resistance to that, but it doesn't mean that they shouldn't try to work together on your behalf if they can.
Yeah. Yeah. And I think what I was going to offer is I think having providers that know the options and that can support that. I think outside of that, it's just as important to have the friend networks, the intergenerational relationships that can also, as and perhaps even with spiritual leaders or psychotherapists or other people that can support the journey that happens outside of the clinic, because not everything is going to be hormone related. As you transition between different periods of your life, as you're starting to feel things and see things anew, right? You might want people who have been there, done that, and can speak to that and support that, or just be angry with you because they're going through it too, you know?
Well, yeah, you think about it, like what's happening during this time period of life. Many people, their kids are growing up, if not empty nesting. We may be caring for ailing parents. I happen to be doing that. We might be in career transition, or looking at the world and going, I'm no longer feeling motivated by what I do because I want to do something that's more emotionally meaningful. Like there's all these
Yeah.
things that also will radically change how you feel in your body, and
Mhm.
just trying to address that by suppressing something with a symptom control, or thinking hormones will cover that gamut. It may not, and I think it's appreciating all those things happening.
I wanted to quickly just throw out there that with the different things that we've outlined, there are also like combinations of things that can be done, or things that can address something specific that people might think of or not think of. So if someone is having sexual side effects, there can be very localized treatments that are not going to go systemic, but they
Mhm.
can help get you back to where you're. It can really bring the tissue back. It can bring the lubrication back. I'm trying not to get too graphic, but I mean, we're
Yeah.
here. So, and I'm very close to menopause, so I almost don't care. So,
Sahara
but
Desert, Sahara Desert.
yeah,
Just give
yeah,
It's,
yeah. So there are things that can be done that people might be worried about, that
Mhm.
that are even being recommended if someone is a cancer survivor. And
Mhm.
actually, some types of BHRT are being recommended to cancer
Yeah.
survivors. But then this doesn't go systemic, and it can give you a little bit of your mojo back, so you don't feel
Yeah.
that loss of that. So just exploring different options and different combinations of things that might work for you as a person, support those adrenals and do a little hormone therapy, or just use it on your vagina. Like that, there are many different ways to approach it.
Yeah.
yeah, absolutely. So vaginal estrogen is such a low dose, there's no systemic effect, but it can bring back the tissue, allow for lubrication, reduce your risk of UTIs and fungal infections, like 87% reduction in UTIs. Right. Every woman over menopausal age should probably have that as an option. But there's also hyaluronic acid suppositories and other things that can help a little bit with the tissue also, because we don't want to take,
HEA.
yeah, DHEA, absolutely. Like we don't want to take that stuff off the table too, right? Like that brings joy to life.
Yeah. Yeah. No, I agree. And I think again, as you kind of transition to how do I reconsider my diet, my lifestyle, my et cetera, it's also a fun time to think through where do I now prioritize and do I want to prioritize sex or whatever else it might be, right? That's a decision point. Yeah.
Yes.
Yeah. And beautifully, thankfully, one that you don't have to make a decision, hold by that forever. There's always that, right? Because we talk often about women who decided to forego BHRT until they were in their 70s. And then they're like, cool, I'm going to try it now.
Yep.
Yeah. 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 The decisions don't have to stand. All right, ladies, we are getting a lot of questions, and so I wonder if we can start that transition over to the questions. Audience, I'm going to remind you that if you do have questions, please toss them into the Q&A section. We do look at the chat, but it tends to be more quick glances, especially when we say like, hey, what supplements are you on? So if it's a longer form question, please do put it in the Q&A area. I'm going to start off first with a question from I believe this is Jolene. So Jolene is asking the question, they're 6 months with no cycle. It sounds like they've done, I'm going to imagine blood work that said high LH and FSH with estrogen sitting around 20. They've experienced weight gain, poor circulation and endurance, and hot flushes. Those are the primary symptoms. They've tried all the herbs, all the acupuncture. They're focusing on clean eating. They're doing a lot of support when it comes to kind of lifestyle, so circadian rhythm and light exposures, red lights, castor oil packs on the liver. Um, any other suggestions? They're at their wits' end, unfortunately, and they're asking if kind of like a BHRT protocol of some sort is appropriate at this juncture.
Yeah, I'll speak to that because that's what my team does every day, all the time. You're in the throes of what I like to call the bungee cord effect, right? Estrogen's all over the place, and we get metabolic changes, which change, how we store fat and how our metabolism works. That's why we see the weight gain, particularly around the middle and all those symptoms. And so often you can even out the bungee cord experience. So instead of, bouncing up and down 2 or 3 stories, we can sort of even it out where it's a much calmer ride by starting hormone replacement before you go all the way to the end, right? You've gone several months without a period, but here it gets weird. You can go like 8, 9 months and all of a sudden you'll have a Hail Mary and starts the clock over, right? Because of course,
Mhm.
let's face the other thing. Menopause is 1 year from the last time you had a cycle, and that is a random choice, right? We have no science to go, there's anything special about that other than we now have confirmed that your cycles have stopped. So BHRT is something to consider here because progesterone has already declined, testosterone has already declined because it declines steadily. It doesn't have the bungee cord effect, but sometimes even stabilizing estrogen a little bit behind this because you could be low. I think that's the thing that I recognized after going back for my master's and my PhD was that I, as an estrogen dominant type, I scream it all the way through the metabolic pathways, all the way through the genetics.
Mm.
I also was terrified of it and recognizing from the literature that, actually you probably needed to start it a lot earlier than I did. So sometimes leveling it out a little bit, and working with a provider that really knows how to do that would be helpful. Yeah, I think it should be on the table. Everybody deserves that conversation. Everybody doesn't need it, but everybody deserves the conversation
Yeah.
for it.
Yeah. Yeah. Dr. Study, anything to add from your lens? No.
Nope.
Love it. All right. Mike has asked a question. Welcome, Mike. We're glad you're here. Mike is saying they're a male. Is there a like a menopause or an andropause? And the answer is yes. So Mike, what we'll do is Vanny or Katie will toss a few links into the chat. We actually did a full summit on this where we explored male health, and I believe andropause was part of that. So it's absolutely a thing. You go through shifts in hormones as well. This isn't exclusive to women, and there should be a lot of support out there. Yeah.
Yeah, men just got a steady roll downhill. You don't have the cliff dive that we have. That's the difference. You don't recognize something's going on until you're like, I just don't feel like myself anymore.
Yeah.
It's slow.
Yeah. 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 Our next question is from Stephanie, and so I believe this will be for Dr. Steady. This arcs back to when you were discussing fiber. So Stephanie is asking, are there any basic guidelines for daily fiber intake? They've been told to aim for about 25 grams per day, and they are post-menopausal.
I think that that's totally fine. But there are people who always think more is better, and I've seen them up, at 75 or 100 grams during a time when their estrogen is low, and it just isn't. It's not. It just may not be necessary, or it may not make you feel good. So it's sort of an individual thing. But I think the
Mhm.
25 grams per day is not too much, in my opinion. But I please either of you, if you have a different opinion, happy to hear it.
Yeah, I would say as long as you felt good. The other thing to think about is when we look about the metabolic changes that happen during menopause and the visceral fat gain, so the stuff around the midsection. The research shows that fiber intake has a direct effect on that, right? So more
Mm.
fiber, better, right? So if you feel fine and 25 is good, then stick with the 25 at the lower end, but it does help reduce visceral fat in a postmenopausal woman.
Mm. Does that literature, because I'm grateful, the nerd in me is grateful that there's a bit of a renaissance when it comes to fiber and that we're starting to tease out concepts of insoluble fiber and soluble fiber. And so audience for the difference, when we think of like um, nuts and seeds and other roughage, that think about more the insoluble side of fiber, right? Flaxseed, psyllium husk. When we think of the soluble side, that's usually more the vegetables of the world. That's not the cleanest of divisions, but you can kind of think about it like that. And for example, when we think of heart health, it's the insoluble fiber that really supports cholesterol and heart health, not actually the soluble fiber. Has the literature dove like, is it nuanced enough that differentiates between the two, or is it still clumping fiber together as one unit?
Years ago, I'd have to dig and see if I can find this. Years ago, there was some small studies looking about soluble fiber
Mm,
and particularly hormone, like because it binds in the gut. But
yeah.
I cannot for the life of me. I mean, it was a much older study. Um,
Hmm.
I think the reality is we want both. One's a whisk broom and the other one's like I call it sticky. One's a whisk broom and one is sticky. We need both. But I think we need a lot more. Do we need a lot more to tell people to eat it? No, I think we need a lot more to understand its impact.
Mm, yeah. Okay. No, fair enough. I like that. I like that. All right. The next question that we have here is saying, uh, without changing exercise or diet, their body fat has decreased from 13.4 to 11.2 as they transitioned. Um, uh, Estrogen kept the fat. Is this normal? I lost almost 5 pounds. Um, so I guess the question is, there was weight loss. Like, I'd be curious a little bit from a body composition perspective, but ladies, any thoughts as to people that go through perimenopause, menopause, and lose weight, which is not typically what you would expect?
Yeah, I would say it's not typical, but we do see that, right? Because
Mm,
part of the reason why we gain body fat is because the fat cells can take testosterone and through enzymatic conversion, make it into estrogen. So the body kind of goes, hey, I got a place where we can make more of this, so we'll do it. But we also have to remember that estrogen and fat are intimately tied together because it's the increase in body fat that brings on puberty, right? So as estrogen levels decline, in some people, I'd be curious, and I don't know this, I can't speak to this, but whether it might be somebody with more of a slightly more androgen,
mm,
estrogen dominant profile that might have more likelihood for weight loss, right?
mm. Yeah. No, that makes sense. So I think if you want to reach out to us, I think this requires a little bit more clinical discernment and background. So we'd be happy to support that understanding, because having enough weight, especially as you get older from a bone perspective, is so very important. Yeah. Yeah. All right. Um, this is going to be an aggregate question, because I've seen several people both in the chat and within our Q&A ask this. So this person's that offered it up, their name is Muffin, which makes me very happy. But this and others, so I'm going to offer the spirit of the question. It's people who say they've been largely fit their entire life, in the sense of, more or less a flat belly. Menopause comes along, and all of a sudden there is a belly, and it is not going away. And it doesn't feel great, because it's not something necessarily that we want, society wants, whatever that might be. What's happening, and how do we go about approaching this?
Yeah. So like I said, the body can instrumentally create more estrogen by bringing on more body fat, right? And then we also have, and where that fat gets deposited is around the abdomen. So we have an increase in visceral fat. The other reason why that happens is estrogen is also anti-inflammatory. So as we go through menopause and lose estrogen, our entire inflammatory cascade and the other thing that we call oxidative stress, so rusting and inflammation, increase. When they increase fat storage viscerally. And so it's sort of this kind of vicious cycle for a lot of women. It can like increasing fiber in the diet actually has shown in studies to reduce some of the visceral fat. Hormone replacement therapy can also do that because it reduces some of the inflammatory response. And then if you're already doing all the diet and lifestyle things, sometimes taking, anti-inflammatory herbals and things like that can drop the fat a little bit, but it may also require, I would say, taking some different approaches from an exercise standpoint too.
Mm.
Sometimes we have to shift what we're doing. Dr. Steady Hardcastle, I'm sure you probably have some additional comments on that one.
Um, well, and in terms of the exercise, definitely, I think that a lot of times like people are still just doing a lot of cardio and doing some weight training, um, either mixing it in or shifting to more of that and a little. I mean, cardio is also important for cardiac health, but in terms of metabolic health, the strength training can be a really a big game changer in that way. Some people do really well with HIIT. to take care of that. Some people get worse when they do hit. And so this is once again where the
Yeah.
genetic component, I know I sound like a broken record, but this is a DNA company production after all. Um,
Yeah.
is
Makes a
it
difference.
I'm here for a reason, right? I believe in it. So that can really help guide how best to handle that. And also
Mhm.
it can say things about, how fats are handled, how starches are handled, and things like that, which sometimes it's a little bit of a shift in what's being eaten, even if you've been fit your whole life. And like Dr. Murray was saying earlier, things that you've done your whole life suddenly just you can't do them anymore, or you can't if you want to feel or look or whatever. If you want a certain effect, you may need to make some changes. And so your genes can guide that, as can a practitioner.
Yeah. Yeah. And even on the weight training thing, sometimes it's even shifting from, a 12, 14 rep, 15 rep kind of thing down to heavy weights, 4 rep, right? Sometimes it's just shifting what you're doing and doing heavier and fewer repetitions because they stimulate the muscles in a completely different metabolic way.
Yep. Yeah. I like that. I like that. And I like Dr. Study, to your point, kind of looping in the genes of it. Because plainly, there's an element of a cheat card there that if you know your body is suboptimal in a way and you can support that directly versus trying to do everything, I'm all about doing less for more. Yeah. Yeah. All right. Our next question is coming from Shelly. So Shelly is saying, they're asking what tools, especially can the Mira tool do this to help them identify where they're in their cycle? Do you want to consider Mira? Do you want to consider Dutch? They say that they've actually been using Mira for quite some time, and but there's some consideration of, is this appropriate for the perimenopause menopausal state? What tools, what tracking would you suggest? So, Dr. Study, I wonder if you can open up a little bit just simply by explaining what Mira is to the audience, because I think a lot of the audience can be familiar with Dutch, but not necessarily Mira. And so, do we want to dive into, from a lab perspective, be that serum, urine, what have you, how we can go about this tracking?
So Mira is an at-home test. It's a urine test. So they send you an analyzer and a little silicone cup and a bunch of wands that test different things. And so every day with morning urine, someone would urinate into the little cup, stick the wand in for 20 seconds, and then pop it in the analyzer. And you do that over many days of the cycle. So it has an advantage over some other testing in that you get more data points. And many of us like more data. And whereas if you go in for a blood, all three of us, right? If you go in for a blood test, um, that's just one point in time, and it could be different 3 days from now. And so it can be a little bit harder to pinpoint the point at which you want to do the Dutch test. And I even found with FSH tests that were just that, and ovulation predictor kits, that because of how they're doing it, that it's a little bit less precise than Mira, and so it can be harder for someone at home to know still when to do the Dutch test. So Mira should be the best tool for this particular situation, but maybe the problem is with not really understanding how to interpret it. Because if you they do a little bit of an interpretation, they'll like send you something that
Mhm.
says looks like you're not ovulating, or something
Yeah.
like that. But that isn't always the information that you're looking for. And
Mhm.
if you don't know how to read all of their stuff, then it may be giving you the information, you just may not know how to do it, not because you're not perfectly intelligent, but because like you're not trained to do that.
Yeah.
So I think that is the best tool for it, if the goal is to do a Dutch test. Yeah.
Yeah. Yeah, I would agree. And it might take you more than one cycle because you don't know
Mhm.
where you're starting. I had an ablation way
Yeah.
back in the day, and you are kind of guessing, you're like, is that ovarian pain? I'm not sure, because you don't know.
Mhm.
And so if you do it a couple months, and what I would do is track when you do it, and on a calendar, like old school calendar, what your values were, because then you'll be able to start to tell, because you should be able to tell, based on the trend value of those hormones that it's testing, kind of where you're at. And that can sort of help you nail it down, but then also know that it can get erratic because you're in perimenopause. But there is the Dutch cycle map. But again, it's really hard to get that done right when you don't have the starting date. And to me, the Mira device, yes, it's a little bit of an upfront cost, but within 2 months, you paid for a cycle map and you can do it again and again and again and again. I love the device.
Yeah. 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 And so for those that are interested in acquiring it, just look in the chat. There is a link. It is a device that we offer here. And it is also a device that with your data, you can come in and we can support the interpretation of that. Yeah. All right. Our next question is coming from Diana. Can you discuss postmenopausal vaginal atrophy and potential remedies or potential approaches to said atrophy? Yeah, glad this came up. All
Yeah.
about sex. Yep.
Yeah, I mean, so we talked a little bit about this earlier. So there's over-the-counter DHEA, right? And there's also prescriptive DHEA and prescriptive vaginal estrogen. Those are probably your strongest support because what they do is they work locally and they help restore the tissue so it gets nice and plump and allows moisture to then be created. There are suppositories like hyaluronic acid that's made in the skin. It keeps your skin plump. You can use those, and everything that I'm saying right here has been approved for even women going through breast cancer treatment because it doesn't go systemically. And you can use that to the day you leave this planet. And especially vaginal estrogen will reduce your risk of UTI, which is a very big risk for women. You start getting into my age group and onward, you don't get burning fire pee and kidney pain. You could have a raging UTI and not know it. You don't get any of the symptoms that we used to get when we're young. And in an older person, it's often confusion, right? And it gets misrepresented. They think it's a decline in mental faculties. And it's like, no, check them for UTI. So, so vaginal estrogen, I'm like one of those things. I think we should have it over the counter like every other country.
Yeah. Preach. Yep. Got it. Any other comments around vaginal atrophy? And yeah, no? Okay. All right. If a woman wants to get ahead of that, what are kind of the prelude symptoms to that vaginal atrophy? Is it simply the discomfort and then pain upon sex?
Yeah, and even things like yeast infections, because when you start to have your hormones shift, the ecosystem down there shifts, so your microbiome isn't the same, and so often we might get more yeast infections. You might get smell changes. You might get tissue discomfort before it becomes significant, right? All of those can be part of that.
Beautiful. All right. Maria is asking a question of they'd love a discussion around osteoporosis following menopause. So for the majority of the audience that's in that postmenopausal category, and they're like, oh dear, better start thinking about this. Let's discuss bones.
Yeah. So in the United States, I don't know if Canada is like this. The current standard of care is to test a woman for osteoporosis at 65. And most of us, we will get diagnosed at that moment. Yeah. Right. And the truth is
but it just starts. Just starts at 65.
No, it's not true. So we hit peak bone density at around 30 on average, right? Give or take, depending on what a woman is doing. So your best case scenario is by about then, and then we have a steady decline. But estrogen promotes the construction of bone and slows down the reabsorption. When you lose estrogen, every woman is losing bone. If you do not replace estrogen, we are all losing bone. However, some had more to start, some lose it more quickly. We know genetics play a role in all these other things, but we're kind of running a race against it, right? Exercise, diet, appropriate nutrition, all of that plays a role. Your K vitamins, your vitamin D3, adequate calcium, preferably from the diet, all play a role. Hormone replacement, just so you know, bioidentical hormone replacement, and even way back in the day, conjugated equine estrogen was approved by the FDA in 1988 for the primary prevention and treatment of osteoporosis. Right? Yeah. So that is on the table. We have lots of women in my telemedicine company that are on bioidentical hormones and doing exercise and things like that and have significant change in bone density without having to do bone drugs. And bone drugs are also that choice. We've been doing osteoporosis for 20 years. So there's lots of opportunities to address it, but you have to work at it because we're losing as just a part of the aging process. Men do too. If you cut off a man's estrogen, you will cut off his ability to build bone.
Yeah. Yeah. So if I'm hearing you, or at least extrapolating a little bit, there's the consideration of BHRT before medications, et cetera, but also the consideration of what are you doing, which includes exercise. So it's not, hormones are not a get out of jail free card, unfortunately.
No. You can't, hormones aren't going to magically rebuild bone. There was some good studies. There was one coming out of Europe and the women were like in their 70s and all they did was weight train them heavy. So 70 to 80%, one rep max. So we're talking, you're only going to do 2 or 3 or 4 of these and then you're going to stop. But they showed significant improvement in bone density, right? So you can do it, but whether you can regain and get out of that osteoporosis zone, often you need bigger guns.
Yeah. So for the people in the back, even at 70, you can to a degree, you can regrow bone. It's not something forever lost.
No.
Yeah.
No, that's a wife tale.
Yeah. Yeah. And I think that's important, right? Because you often see people that are kind of, 65, 70, and they're like, but I'm old, so I can't do anything. And that's not true.
That's not true.
Yeah. All right. Karen is asking a question. So they acknowledge they haven't seen the other 2 installments of this series that we've done, but their question is specific to BHRT. They're saying that they beautifully don't really, so they're postmenopausal. And they're not really presenting with any of the typical symptoms insofar as there's no brain fog, no hot flushes, no shifts, no detrimental shifts in body composition. And they're wondering, in this instance, is there a case still to be made to take BHRT, in an appropriate way for their body? Would that be someone that, like, do we exclusively use and Dr. Betty, I know your answer to this one.
You know what I'm going to say.
I'm staging you here.
Yes,
Is BHRT kind of treated like an SSRI or, an insomnia medication where it's symptomatic relief only, or is there a case for it outside of that?
100% there's a case for it outside of that. So, and it depends on which society and who you're talking to, right? So again, Western medicine looks at a symptom and tries to suppress symptoms, right? So a lot of the old recommendations were based on, give it for hot flashes, and when they go away, then you can stop taking it. But the research clearly shows today, particularly when it started earlier, but that doesn't mean that you can't start it later. Started earlier in the process within the first 10 years, you can reduce the risk for dementia, heart attack, stroke, all-cause mortality, breast cancer, ovarian cancer, lung cancer, colon cancer. All causes of dying are reduced when hormone replacement therapy is started and continued. Now, if you're 75 and have never had hormones, it doesn't mean that you can't take them. It's just some of the restorative properties. And it really is, think of it this way. It's kind of like investing. If I put money in the bank when I'm 20, or in an investment account when I'm 20, my payoff is greater at the end, right? Because of time. Right? Same thing. So if I start investing and putting hormones in as my body is transitioning, I don't have the shrinking of the brain, I don't have the remapping of the brain, I don't have the bone loss, I don't have the vascular inflammation. All of those things start when we go through menopause and they accelerate, right, as we get older. If I stave that off and I don't give it a chance to start, I have my best case scenario. Right? That's where those numbers are, like, depending on the study, 24 to 31% reduced risk for dementia, right? So I look at it and I go, I don't really care if you're having hot flashes. I know they sting, but I care about, because what I care about is we outlive men by 4.5 years, but our health span is worse. So we're more likely to be in a nursing home, confined to a wheelchair, unable to feed ourselves. That's what I care about. And so, even if you're not symptomatic, we know those things are happening. And so starting hormone replacement therapy, again, we don't do high doses, they're low doses, can help reduce some of those inflammatory activities, but it doesn't mean everybody needs it, right? But the stats are there.
Yeah. Yeah. I think it's important to recognize, and I've heard you say this, so I'm just echoing Dr. Murray, what you're saying. 200 years ago, once you hit menopause, maybe you had a decade left of life. And there are many reasons for that.
Yeah.
But now that once you hit menopause, and assuming that's at 50, maybe you're at 40, whatever it might be, you're looking at, 20, 30, 40, maybe even 50 years.
Yeah. A third of your life.
Half your life. Yeah, half to a third.
Yeah. Yeah. Our lifespan was barely 50 in 1900, barely 50.
Yeah.
So you didn't even get a chance to knock on the door. We should be excited that we're still here. So if you're postmenopausal, like thumbs up, fist high, we're still here.
Yeah.
Hold on.
All right. I think this question is going to be for Dr. Steady. Tony is asking, they're saying that they're 15 to 20 years postmenopause, and they're still having hot flushes. They're not able to sleep through the night because of it. They are open to any and all herbal or natural remedies. Is there a chance that herbal natural remedies is something that this can support? So Tony, obviously, I would speculate Dr. Steady is going to have so many questions to refine. So Dr. Steady will be speaking in generalities, but if you want to talk to her directly, feel free to email us. But Dr. Steady, in general, can someone who's 15, 20 years still struggling with hot flushes, is that something that herbs and supplements can support with?
The amount of time that someone has been struggling with those doesn't really impact whether or not the treatment will work. So I think that it would definitely be worth trying. And of course, there's, different people respond differently to different things, but I definitely think if you're suffering, seek out whatever methodology resonates with your values and your priorities, and seek the help, because there's just suffering and thinking there's no hope is really not something that we should have to do in this day and age, right?
Yeah.
Yeah. I want to talk just briefly for about a second about a
Yeah.
non-supplemental, non-dietary thing that may help some people sleep. Shameless plug, there's several companies out there. I have a particular one, but Chili sleep pads. They're pads that go on.
Mm,
They have
mhm,
a little
mhm.
water container device. So think of it as like a
Yeah.
little air
A little
conditioner.
refrigerator.
The little refrigerator, and it runs cold water through this little pad on the bed. The new ones are AI. They constantly are checking your body temperature and sort of managing it, because we know people stay asleep when their core body temperature stays low, right? So that's your core body temperature here. A lot of us may not have hot flashes, but we might also sleep hot. And so core body temperature changes in both men and women can help. They're expensive. So what I say is have your family pull together. That's the Christmas present for mama.
Mhm.
I love
Yeah.
mine. I'm trying to figure out how to take it with me when I travel.
I have one too,
Too big.
because my last space didn't have air conditioning. In the summer it would get really hot, and so I leveraged it as my air conditioning in the summer. And I'm in a space now with air conditioning and I still use it. I'm so
It's just money.
profoundly addicted to it.
Yeah, and it
So
warms up
addicted to
too.
it.
So for the people that are worried about being cold, I'm cold when I first go to sleep and then I cool it off. But it actually saved us money because we weren't cooling half of the house to try and get the temperature in the bedroom cool enough. We actually leave it at a warmer temperature because it keeps you cool. It's amazing. I was like best invention ever for sleep
I
outside of
know.
all the things we're talking
I
about.
know. I know. And I'm someone that hates the cold, and yet here I am. Here we
Yeah.
are. All right. Stephanie has an off-topic question, and I'm curious of the answer to this one because I haven't heard of this before. They're asking that they read somewhere that the vaginal estrogen cream can be repurposed and put on the face for wrinkle prevention. Any thoughts
It
on
can.
that?
Yeah, it
There we
can.
go.
It can. Now, shameless plug, I actually produce a topical cosmetic use biased, so estriol, estradiol facial cream with aloe, shea, and jojoba oil. But so essentially, when you put estrogen topically, it's going to plump up and allow for collagen production in the skin. So it reduces wrinkles and plumps up the skin and keeps the skin softer and whatever. That's just
What we were saying it does for the vagina, it will
yeah.
also do for the face.
All over. Yeah, it's just, I look at it and I'm like, I want a better quality thing on my face, but people do it. People use
Mhm.
natural estrogen for that, but that's why I created the topical one.
I love it so very much. And is
I
that
use it
something
every
that
night.
is that something that women need to be systemically worried about? Will that like the topical
It's
application to the face?
it's like a teardrop, like a little tiny bit. Now, if you were pumping it all over the body, could you get some systemic effect? Like you don't want to lube up the whole body. You're just putting a little, like I put a little tiny bit and I mixed it in with all my other stuff and then just,
Yeah. Okay. All
yeah.
right. There we go. You learn something every day. That's
Yeah.
something. All right. Next question is from Krista. Oh, hey, Krista. What is your perspective on HRT seeding? Is that more effective and is it safe?
Seeding, are we talking about like pellets?
That I was actually kind of hoping you guys would know. I haven't heard this phrase before. I've heard of like seed protocols, but never like
Yeah,
an
I was gonna say
HRT
seed.
seed.
Yeah, I
I
definitely
know
have
seed
seed
protocols.
cycling. Yeah, seed cycling protocols for fertility. Yeah, I'm assuming, Krista, you might be talking about pellet therapy, right? So pellets look like little tiny seeds. They're about the size of the tip of a Bic
Yeah.
pen, and they make a small incision and they shove them in the fatty tissue right at the fat and the muscle fascia, right on the top of the buttocks, and you slowly absorb them. They are bioidentical, right? All of that comes down to the person installing those and how they calculate what you need, because they're in your butt. They're there for like 3 to 4 months, right? They take about 3 to 4 months to absorb. So, and so they hit sort of a peak absorption and slowly absorb over time. In my physical clinic, we use them, but we don't use them near as much as we use the other ones because everybody metabolizes things a little differently. So you just have to have somebody that really knows what they're doing, right? Because if you go to just the classic, hormone place on the corner, that's all they do, they usually overdose. I'm just being honest because they're all based in Dallas. They're all in my backyard.
Yeah, no. I like that answer because it opens up different ways, especially for the forgetful. That could be something
Yeah,
very helpful to the
yeah.
forgetful.
And I'll be full disclosure. I've had every company in my butt. I have used every form of hormone, and then I run tests. I'm your lab rat just for you, right? Because I just want to know. I'm like, what happens? I've
Yeah.
done.
Yeah, Katie and Vanny, I think we should take a happy little clip of Dr. Betty saying, I've had every company in my butt. All right, next question.
We add that to the pillow we talked about earlier. So there we just add to the off color things that you get to
It's
sniff.
going to be our end of year Be Real for you, Medell.
My sizzle reel.
Sorry.
My sizzle reel, all the things we have Betty say on social media.
Yep. All right, Susan has the next question here for us. So, Susan was prescribed HRT 8 years ago to help with inflammation secondary to their RA, so rheumatoid arthritis. They're 12 years postmenopausal as well. They were recently told by their doctor that HRT does not help this. I'm going to speculate they mean menopause, given it was prescribed for the RA. What are your thoughts on this? And so Susan, I don't know if we'd be able to fully answer this question for you. And the reason is we don't know that prescription that was originally given to support the RA. So there may be truth in the sense of the hormones you're being given for RA are not necessarily going to be targeting the same things as menopause. So this might be something, if you want support with this, please feel free to reach out because we need to review the specific prescriptions and kind of the case history there. And I think DNA would be supportive to guiding that answer there, in particular towards the RA side of things. I think DNA is really helpful in understanding what sort of perimenopause to expect and how you can support that. But when I think of larger systemic things, I think our panel would be really helpful to support that larger picture of RA. So feel free to reach out to us. But I don't know, Betty, if you have you look like you have something on the tip of your
Yeah,
tongue.
I can't help myself. I mean, we know, okay, so systemically changes in hormones like fluctuations in estrogens post pregnancy, perimenopause, menopause, low levels of testosterone, changes even in progesterone can initiate inflammatory response associated with autoimmune, right? We have the onset of autoimmune that happens in these sort of very hormonal buckets. It's not directly related, but there's a correlation between the changes in hormones and inflammatory and immune control response, because estrogen controlled and balanced balances the immune system, but very high estrogen stimulates it, right? And progesterone kind of calms it down. So could hormone replacement therapy be part of a picture of balancing somebody to reduce overall inflammatory load for autoimmune stuff? Yes, but not directly, like it's not direct anti-inflammatory. But your DNA would also help you inform. I agree with that completely as to kind of why that may be more so or less so for you. Oh, you are unmuted.
You're muted.
Of course I am. I have a nasty post-viral cough, and so I mute myself so that the world does not need to hear it. And here we are. All right. Stephanie has a follow-up question for you, Dr. Steady. Um, so and this is in regards to fiber. I've definitely they have increased belly fat post-menopause. And if they were to experiment with increasing fiber above 25 grams, what potential issues should they look for to indicate that they're potentially having, they've tipped a little bit too far beyond where they should be?
So I say, first of all, go up slowly, just because extra fiber can sometimes make people feel digestively funky.
World
So
War
you,
Three.
so you, so, so increasing that slowly, would be a good thing to do just in general. And then, if you start to notice that you, are having any of the symptoms that we've described, with having low estrogen, then, you could kind of back it off by 5 grams of fiber and see how you feel. And just because something, might make you feel less good initially, it doesn't necessarily mean it would be that way forever. So you could back it off and then try going up again, is what I would say. I eat a lot of fiber myself because I can tolerate
No,
that.
shocking.
For I know. But I just have seen sometimes people go leaping up in their fiber and having just all sorts of, um, uncomfortable feelings around that. And so I would just encourage you, like I
Mhm.
said, to slowly ease yourself.
Yeah. And I would say, there's no yes, it can help you detox and it can, alter things because of that, but there's no upper tolerable limit of fiber, right? When they've done studies looking at, recovery of Paleolithic men and the Utsi, the guy we found that was like frozen in a cave, quite literally intact. So we knew like his stomach contents were intact. We know that if we look at more ancient man, we ate a ton of fiber. We were not carnivores. We were omnivores. We were opportunistic. So, there's not necessarily an upper tolerable limit as long as it doesn't cause
Mhm.
problems for you digestively.
Mhm. Yeah. Yeah. No.
Yeah, I have people in my life that once they reach a certain point, things just are coming out so quickly that they're not absorbing things
Yes.
anymore. And that's fairly obvious to them.
Yeah.
So I'm just going to
Mhm.
throw that out there.
Yeah. Yeah. When you're like, I need to know where
Yes.
the bathroom is at all times, that's too much.
Yeah. Yeah. All right. Our last question here is from Eloise, and we have touched on this in.
40713.
Ooh.
Oh, all
Sorry.
right. No, that's okay. We're just going to get you to mute for a second. Dr. Study just has to attend something. So if you just want to mute yourself, or maybe oh, perfect. There we go. All right, Dr. Murray, this is all you. So I think we've seen, again, different flavors of this, but I want to add in a few extra dimensions to those questions. So Eloise is saying that they are a woman with PCOS. They're in their late 40s, very active in the gym. They lift heavy weights, but they're struggling with that big tummy. What would you suggest, especially kind of with this variable of PCOS? So walking into menopause we know that all women are going to not necessarily walk in with kind of like an unremarkable hormonal history. There's going to be endometriosis, there's going to be PCOS. So in the instance of PCOS and there's the belly, what suggestions do you have there? What thoughts do you have there?
Yeah, because there's variations on PCOS, right? And for anybody that
Yeah.
doesn't know what it is, that's polycystic ovarian syndrome, where you don't really ovulate all the time. The ovaries get sort of bumpy because the eggs don't pop out, so they become polycystic. It's often, so one of the classic sort of presentations is associated with sort of an inherited insulin resistance. And so it's intimately tied to blood sugar and insulin. Right. And so those of us who have PCOS, and it doesn't necessarily mean that you didn't have periods either, because you can still have periods and have PCOS. It's sort of a continuum.
Mm-hmm.
So we have this sort of uphill battle against the metabolic effects of that. Right. And you got to remember, this happened because it kept us alive. right? Insulin resistance kept us alive as humans. It's there for a reason. It's just no longer valuable now, right? Like we get mad about it, but it's like, no, that's what kept our ancestors alive.
Yeah.
You know, the person is like, I have a salad and I don't want anything else. They didn't survive, right? You need to put food away and keep it. That's what humans are wired for. That's why we conserve
Yeah.
very well, right? And as women, we conserve very well. Well,
Mhm.
what's interesting is when estrogen fluctuates, that gets exacerbated. And so often we kind of see all of that go together. There are some, I don't generally make recommendations, but, you know, if we look at some of the metabolic research, you know, some of the drug research is often using things like metformin, you know, GLP, GIPs, because it affects the liver and the insulin control that can affect those pathways. Berberine, dihydroberberine are all things like that. Chiroinositol and myoinositol are also very, very good supplemental ingredients that help. And there's been studies looking at postmenopausal women and reversing insulin resistance in 8 weeks in a statistically significant portion of the population.
Mm.
So even adding that and doing other stuff, and then it might be looking at, you know, possibly putting in hormone replacement to sort of stabilize the sort of underpinnings of what's happening. It's harder if you're somebody that had PCOS. It is, you know, on that continuum also. It's just a little harder because you're not as kind of textbook. You know, genetics, knowing your genetics is helpful here too. Very, 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 very helpful.
Yeah. Yeah. Beautiful. Yeah, I agree with the genetics there in particular for kind of the nuanced cases, as well as really integrative supportive care.
Yeah.
Because I think landing in a good definition of where you fall on that PCOS spectrum and what your collection of symptoms to get you bucketed into a syndrome is really important. Yeah.
Yeah. Yeah. And if all those things don't hold true, start looking at cortisol.
Yeah. 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 Okay, Medalls. This was delightful. I'm very grateful and glad we had this sort of conversation because as someone that has been party to a lot of the menopause conversations, it's often because BHRT is such a wonderful solution and so under discussed, we tend to focus on that. And that's important because that information isn't out there and women need that information. That said, I'm really grateful that we were able to jump into a space and talk about, for those that for whatever reason it's not appropriate, what else is on their table? What other options do they get to pick and choose from? So I'm grateful that we got to sit and have this conversation. Yeah. Dr. Steady, you're a delightful addition. Thank you very much. We're grateful to have you. And Dr. Murray, as always. It is so very wonderful. Yeah. And so, audience, thank you so very much. This is a continuing series. We'll probably catch you, I would guess, next month, but time doesn't exist. So, in about 4 weeks from now, you're going to see us and we're going to be discussing menopause again. If you have thoughts or questions or anything you want us to be addressing in that, please do not hesitate to reach out to us and let us know. We show up and we do this for you. So, we want to know how we can support you. If you're looking for continuing care from us, do not hesitate to reach out to CEO at thednacompany.com. These brilliant ladies that are before you can all be accessed in part through that because we want to make sure that we're serving you and your health. All right, ladies, I think it's the time of day where we get to dance out. Are we ready? Yes, ma'am, Dr. Steady. Come on, this is how we jump out of these sessions. So, audience for awareness, when we talk about exercise, and exercise will support mental health, but what is the best exercise as proven by science and research? For that, it is dancing. So, we dance out every single time, and we hope you dance with us. Au revoir, mes amis. Au revoir.